Alright guys, sorry, some technical issue from the YouTube side. We were not expecting that to happen. I mean, क्या करें अब अच्छी चीजें होती है तो नजर भी लगती है. So I think that is one of it. I'm so sorry. Something wrong went from the YouTube side. The link got crashed, so we have to recreate the link. I hope you guys are joined back again. Are you guys there? Sorry. अब क्या करें, हमारी कामयाबी इतनी होगी कि YouTube को भी थोड़ा खटकने लगा. कोई नहीं, कोई दिक्कत नहीं. Right. So I hope you guys are there. I'm so sorry. I'm so sorry. It's from the YouTube glitch that we had. It has been fixed. We are back again. So let's do our thing. Okay? Yeah, let's continue. So yesterday when we spoke about it, we spoke about the Barrett's esophagus. We spoke about how do you diagnose it and what are the interpretations that you can get on a Barrett's esophagus when you're doing an upper GI endoscopy and its finding. Now, another very interesting thing is if you ever come across an algorithm that how do you approach a patient of Barrett's esophagus. Now, there is a small algorithm that is given in our Bailey and Love as well. Now, it says any patient who is suspected to have Barrett's. Let's say any patient who is suspected to have Barrett's, we'll say there is presence of columnar metaplasia, right? So this presence of, we call it as presence of flat columnar patient of metaplasia. We've discussed yesterday, no? It is a dysplasia that is irreversible, whereas metaplasia is a reversible state. So we adhere to the same point as well, right? Now what you will do is you will do a biopsy to confirm it. So we are going to do something called as the systemic cold biopsy. Sorry. To do a systematic. We do a systematic cold biopsy, a fancy word to tell you a frozen section on in general, right? Right. Now this systematic cold biopsy is now going to give me a yield. So what we'll do is I'm going to do an upper GI endoscopy, see if there is any changes like red velvety mucosa, take a chunk of tissue and give it to Ranjit sir. And we say, Ranjit sir, kindly help us to make us a diagnosis. Now when you look across here, what can our Ranjit sir tell you about this? Now the first thing that he can tell you is there any changes present or not, right? So obviously we are concerned about that. So that is what we are going to look across. So we'll say, is there any effective changes which are going to be present or not? Now, the first thing, there could be no dysplasia. There could be no dysplasia. Second, there could be suspicious of dysplasia. It is not confirmatory, so we call it as the indefinite for dysplasia. Suspicious or indefinite for dysplasia. There is this indefinite state for dysplasia. Then you have a low grade dysplasia. Then you can have a low grade dysplasia can be present, or there could be a high grade dysplasia. So there could be a high grade dysplasia. Or there could be a high grade dysplasia. Right, so based upon the histopathology, I can divide them into 4 categories. Either there is no dysplasia, or there is indefinite form of dysplasia, or there is a low grade dysplasia, or there could be a high grade dysplasia. Now, as we have learned yesterday, whenever you have a no dysplasia, I will see the length of the metaplasia. I will see the length of the metaplasia. So when I say the length of the metaplasia, that is what we have red velvety mucosa that we have measured yesterday. This length of the metaplasia will either be less than 3 centimeters, either it could be less than 3 centimeters, or it will be more than 3 centimeters, right? If it is less than 3 centimeters, Then you have to repeat. You have to repeat upper GI endoscopy, right? Now, on a repeat endoscopy, again, if you see the length increases, you'll go to this phenomena. Otherwise, you can discharge the patient. There will be discharge and follow-up. Now, the question is, your patient will ask when to come back for follow-up. You have to tell the patient that you have to get the upper GI endoscopy every 3 to 5 years. Between every 3 to 5 years, repeat upper GI endoscopy, and that is the criteria for follow-up in these patients. Okay? So we have measured the length of the dysplasia. If the length of the dysplasia is less than 3 centimeters, you will repeat again to look for the component on the upper GI endoscopy. You will see if it is increase in length or not. If there is no increase in length, discharge the patient, ask the patient to come back after 3 to 5 years, right? Now, if it is more than 3 centimeters, then repeat upper GI endoscopy every 2 to 3 years. So the frequency is changing. If it is less than 3, I will repeat in 3 to 5 years. If it is more than 3, I will repeat in 2 to 3 years. I will repeat in 2 to 3 years if there is no dysplasia that we have agreed upon, right? Now, on the other hand, if there is an indefinite form of dysplasia, if there is indefinite, here you have to repeat. Here you have to start the patient on proton pump inhibitors for acid suppression. After that, repeat upper GI endoscopy, right? So you give a proton pump inhibitor, suppress the symptoms, and then repeat an upper GI endoscopy, right? If there is a low grade dysplasia, you have to do an upper GI endoscopy every 6 months. Do an upper GI endoscopy every 6 months. Now, until what point, right? Then you need to have 2 consecutive upper GI endoscopies free from dysplasia, right? So you need to have 2 consecutive. You will do this until 2 consecutive, until you have 2 consecutive, until you have 2 consecutive non-dysplastic biopsy. We will continue for this. If it is a high grade dysplasia, then as we discussed yesterday, you have to go with endoscopic mucosal resection. You have to go with endoscopic mucosal resection, right? Now, this is the chart that we follow for your upper GI endoscopies in Barrett's esophagus. Many a times the confusion is, if there is no dysplasia, when will you ask the patient to come back? You look at the length of the dysplastic segment, less than 3 or more than 3, less than 3, see, if it is less than 3, the follow-up is going to be from 3 to 5 years, right? If it is less than 3, the follow-up is going to be after 3 to 5 years, and if it is more than 3, the follow-up is going to be 2 to 3 years, right? On the other hand, if you have a low grade dysplasia, then I will do an upper GI endoscopy every 6 monthly till I get 2 consecutive non-dysplastic biopsies. If it is an indeterminate one, how do you determine it? Start the patient on proton pump inhibitors and now take the patient for upper GI endoscopy. Now take the patient for upper GI endoscopy. If it is in high grade, go with intervention that is going to be an endoscopic mucosal resection, and that is how you're going to deal with your Barrett's in general. Hi Parmeet, thank you for joining us. Now, as we all know, we need to understand when a patient comes to you with suspicion of GERD, how would you like to investigate, right? So the investigations that you will do, now we're going to move to the investigations. The investigations that you will be performing for GERD, right? If a patient is suspicious to have a gastroesophageal reflux disease, the first one that I can do is a 24 hours pH monitoring. We'll do a 24 hours pH monitoring. Now, what is this 24 hours pH monitoring is? Normally, when you look at this, there is this pH probe that is going to be present. Let's say this is the pH probe, and this probe will go into your stomach. We'll show it in a while. And then there is nowadays most of them are ambulatory. So there is this recording that you will have, and this is that device that is going to be present. So what we do is we take this 24 hours pH monitoring and we are going to insert that into the patient. So with the same as you put a nasogastric tube or a Ryle's tube, in the same fashion, we are going to insert this into the esophagus. So what I do is I'm going to put this pH probe. It goes into the esophagus. It goes into the esophagus. From there, it is going to go into the stomach, right? Now you need to understand that this pH probe is now connected with a device which is here. Now this device is usually capable of measuring the pH fluctuation that usually happens inside this part. There are two sensors which are present. One is going to be an esophageal sensor. Another one is going to be the gastric sensor, and I'm hoping this is your gastroesophageal junction, right? So there are two sensors in a 24 hours pH monitoring. The first sensor that you have here, this is what we call it as the esophageal sensor. This is what we call it as an esophageal sensor, and this is what we call it as the gastric sensor. So one you have a esophageal sensor, another one you have a gastric sensor. Now these are the two sensors which are going to measure the pH across here. So logically talking, no, if you understand the whole interpretation, the pH of the stomach, when you look at the pH of the stomach is going to be anywhere between 1.5 to 2. It is acidic. We expect an alkaline, or we can say we expect a pH of more than 4 in the esophageal sensor. We're talking about normal. When we talk about what is the normal esophageal pH and what is a gastric pH, normally we'll say esophagus it should be more than 4, and gastric sensors the stomach pH is around 1.5 to 2. If you have a reading which is telling you that a gastric pH is this and the esophageal pH is more than 4, it means it is normal. Imagine if there is an acid reflux. Every time there has to be an acid reflux, what will happen? The acid will now go into the esophagus. Now, if it goes into the esophagus, this esophageal sensor which is present will detect this acid reflux. Now, once it detects its acid reflux, it will now be able to tell me that the pH, obviously when the acid is going from the stomach into the esophagus, the pH will drop. Our goal is to find out the number of times or the number of attempts, or I can say number of refluxes from the stomach into the esophagus that is lowering the pH less than 4. As simple as that. मैं फिर से थोड़ा हिंदी में बता देता हूँ. मोटा मोटा ये है कि स्टमक का पीएच ना 1.5 to 2 होता है और ईसोफेजियल पीएच 4 से ऊपर होना चाहिए. ठीक है, ये अपने को एस्टैब्लिश फैक्ट है. अब मानिए कि अगर मेरा पीएच रीडर बोल रहा है कि भाई आपके गैस्ट्रिक पीएच इज 2, ओके फाइन. फिर बोलता है कि आपका ईसोफेजियल पीएच 4 से कम आ रहा है. इसका मतलब क्या है? पीएच कब ड्रॉप करेगा? जब रिफ्लक्स फ्रॉम द स्टमक इनटू द ईसोफेगस विल हैपन. जब बार बार रिफ्लक्स करेगा तो जितनी बार एसिड जाएगा उतनी बार पीएच 4 के नीचे ड्रॉप करेगा, और जितनी बार ड्रॉप करेगा उससे मुझे ये पता चलेगा ना कि 24 आवर्स पीरियड में एक ईसोफेगस को कितनी बार आपका पीएच ड्रॉप कर रहा है, मतलब उतनी बार रिफ्लक्स हो रहा है, और जितना ज्यादा रिफ्लक्स होगा उतना ज्यादा प्रॉब्लम है. सो वी विल सी एन एवरेज ऑफ दैट 24 आवर्स. उसको एक डीमिस्टर स्कोर बोलते हैं. इतना याद रखना 24 आवर्स पीएच में ना, जैसे अब ये पीएच लेस देन 4 पीएच लेस देन 4 वी आर ट्राइंग टू मॉनिटर, तो इन सब को एक ही साथ जोड़ने के लिए वी हैव अ स्कोर एंड दैट इज व्हाट वी कॉल इट एज अ डीमिस्टर स्कोर. ठीक है, तो इसका इंटरप्रिटेशन भी बता दूंगा. इट्स अ वेरी ब्यूटीफुल इंटरप्रिटेशन दैट यू हैव, दैट हाउ मच शुड बी योर डीमिस्टर स्कोर. हम बोलते हैं कि अगर डीमिस्टर स्कोर मोर देन और इक्वल टू 14.7 है, इट इज कॉन्फर्मेटरी ऑफ जीआरडी. ठीक है, इट इज कॉन्फर्मेटरी ऑफ जीआरडी. तो ये यही बता रहा है कि अगर आपका डीमिस्टर स्कोर is going to be more than or equal to 14.7, then I will say the patient is having absolutely GRD. There is no doubt about it. ठीक है, क्या बोल रहे हो सर? पेशेंट को 24 आवर्स वार्ड में रखना है. आइडियली पेशेंट को आप वार्ड में रख सकते हो. अदरवाइज नाउ आजकल जितने भी पीएच मॉनिटरिंग आती है ना, ये पोर्टेबल पीएच के साथ आता है. तो पोर्टेबल पीएच में ना पेशेंट को स्लिंग बैग देंगे, उसके अंदर रहेगा, नाक में ये रहेगी, एंड देन द पेशेंट विल कंटिन्यू टू मूव ऑन. ठीक है, तो ये आपका 24 आवर्स पीएच मॉनिटरिंग है. फिर से बता रहा हूं, 24 आवर्स पीएच मॉनिटरिंग में एक पीएच प्रोब डलता है, उसकी एक मशीन होती है, नेसोगैस्ट्रिक ट्यूब के थ्रू इट इज गोइंग टू गो इनटू द टमी. नाउ यू विल बी एबल टू पोजीशन इट. इतना याद रख लेना, ये पोजीशन ऑफ दी सेंसर्स आर इंपॉर्टेंट. तो अगर आप देखोगे ये जो ईसोफेजियल सेंसर है और ये गैस्ट्रिक सेंसर है और ये आपका गैस्ट्रो ईसोफेजियल जंक्शन, वी से इट इज यूजुअली 5 सेंटीमीटर्स अबव द गैस्ट्रो ईसोफेजियल जंक्शन। जो आपका ईसोफेजियल सेंसर है, इट इज गोइंग टू बी 5 सेंटीमीटर्स अबव द गैस्ट्रिक सेंसर, इज गोइंग टू बी 5 सेंटीmeters below the gastroesophageal junction. Equidistant you are going to place it so that you will be able to pick up the pH status. ठीक है, so this is what we call it as a 24 hours pH monitoring. Now आज के डेट पे there is 48 hours pH also. We have 48 hours pH monitoring. We have 72 hours. The only objective is कि जितना ज़्यादा डेटा लोगे उतना ज़्यादा बेटर इंटरप्रिटेशन होगा. You have 90, I think 96 hours is also there. हाईएस्ट जो अभी हम कर रहे हैं, it is a 96 hours pH monitoring. Doesn't matter much, but more or less 24 hours is still considered to be the gold standard. ये करना है, ठीक है. 24 hours pH करोगे, लेकिन जैसे जैसे the more you add on to the data, you are only increasing the sensitivity of the investigation. ठीक है. अच्छा, एक और है, there is something called as impedance pH monitoring. There is something called as the impedance. There is an impedance pH monitoring. Now इसका भी समझ लेते हैं. What do you mean by an impedance pH monitoring? Now the problem is, if you look at our standard 24 hours pH, ये आपका esophagus होगा. This is going to be the stomach. I'm just going to compare what is going to happen when you use our standard pH monitoring. ये आपका 24 hours pH monitoring है, right? For the sake of understanding, we'll just label this. This is our 24 hours pH. ठीक है. We just learned that there are two sensors which are going to be present. One sensor is going to be in the esophagus, another one is going to be in the stomach, right? So you have an esophageal sensor and there is a gastric sensor that is present, and obviously this is your gastroesophageal junction. What are you trying to understand? Every time there is a reflux, esophageal sensor, there will be drop in pH. That is, so I can only tell you whether the pH is dropping or not, right? So there could be non-acidic reflux also, there will be gaseous reflux also, there will be liquid reflux, there will be solid reflux. So how do you know that it is in that form? See, 24 hours pH monitoring is only going to tell you whether the pH drops or not. It is not going to tell you that is it going to be a refluxive component because of other reasons also. There is non-acidic reflux also. So we will not be able to know whether is there any form of non-acidic reflux, because that will tell me what is the status of the lower esophageal sphincter. No, my goal is to reconsider or I have to reform this lower esophageal sphincter. Problem क्या है कि 24 hours pH monitoring में सिर्फ ये बता रहा है कि pH drop हो रहा है कि नहीं हो रहा है. I need to understand that if okay, one, the pH is dropping or not. Second, I need to know whether it is a liquid, whether it's a liquid reflux. So I need to know whether it is a solid reflux, whether it is a liquid reflux, and number three, whether it is a gaseous reflux, right? On the other hand, I also need to know the extent of the reflux. I also need to know the extent of the reflux. So when I say the extent of the reflux, it means is it in the lower esophagus? Is the reflux going all the way to mid? Is it reaching all the way to that of the to the mouth? So in that I need to know कि कितना ऊपर तक reflux जा रहा है. तो आपका जो impedance pH monitoring है, it says we will now come up with a new variety of probe. So this is how an impedance pH monitoring probe would look like. Now, what is so special about this is this impedance pH monitoring probe will have multiple sensors. Now, to be precise, they will have 36 sensors 1 centimeter apart. So, this is going to have multiple sensors are going to be present. So, this impedance pH monitoring, they are going to have multiple sensors. So, we'll just name them as Z1 sensor. This is your Z2 sensor. You have Z3 sensor. So, ऐसे करके there are total of 36 sensors. There are 36 sensors. Distance between each sensor, it is going to be 1 centimeter apart. So these are usually 1 centimeter apart. So what is the advantage? The advantage is now when I put Now when I put this sensor, you see there are multiple sensors which are present. So they are present at multiple locations that you have. As I told you, precisely 36 sensors, 1 centimeter apart. So every time there's a reflux, right? Now imagine that every time there's a reflux. Now as the reflux goes, I know what form of a reflux it is it solid, liquid or gas? I also know the extent of the reflux. I also know the extent of the reflux. तो मुझे ये भी बताता है कि एक तो ये एयर है, गैस है, सॉलिड है, लिक्विड है, क्या है. On the other hand, it will also tell me कि कितनी ऊपर तक reflux कर रहा है. So hence impedance pH monitoring is now considered, the impedance is now superior. Impedance pH monitoring is now considered to be superior. ठीक है. So hence they will provide you with a better understanding and the results. ठीक है. So these lectures are same as in the app or not? Okay. Uh, However, these lectures are quite extensive because we are covering the entire textbook, every topic by topic, every single concept. In our app lectures, they are very much similar to this, but then again, because they are for the competitive exams, they're in a very concise manner. Okay, so explanation in the app is going to be very crisp in a very presentable manner. Here we will have a very elaborate discussion so that our concepts and the basics are quite strong here. So the objective of doing the BLS in YouTube is to have that leverage of explaining every single thing. For example, here हम अगर आप ऐप में पढ़ाओगे, ऐप में हमने इतना बताया कि क्योंकि कॉम्पिटिटिव एग्जाम है, यू हैव लॉट ऑफ डेटा टू प्रोसेस इट, विल ओनली टेल यू 24 hours pH monitoring, probe and all this. Impedance में this is what the objective is. The whole explanation of the idea, why did you come up with impedance, what is the meaning of impedance, what does impedance do, is better explained here. So again, it is all about the amount of information that you can process it. For competitive exams, I highly recommend you to go down to the app. But if you are a final year student or an intern or a third year student where you want to understand each and every single concept what we are going to deal with, then BLS is the best source that you're gonna have. Clear? ठीक है. अच्छा. So this is about your impedance pH monitoring. एक और नया है, जो नया हमारे पास है उसको हम बोलते हैं capsule pH monitoring. The new one that we have is what we call it as the capsule pH monitoring. We have something called as the capsule pH monitoring. इस पूरे प्रॉब्लम में ना पीएच मॉनिटरिंग में ये जो प्रोब था, इट वाज ऑलवेज स्टिकिंग आउट फ्रॉम द नोज एंड इट हैड टू स्टे फॉर 24 hours, 48 hours एंड लॉन्गर ड्यूरेशन ऑफ टाइम. सो पेशेंट्स वर गेटिंग इम्पेशेंट. ठीक है. सो वी केम अप कि काम करते हैं, एक कैप्सूल पीएच के साथ आते हैं और कैप्सूल पीएच मॉनिटरिंग. नाउ दिस कैप्सूल पीएच मॉनिटरिंग, sorry, this capsule pH monitoring is now considered to be as one of the greatest leap that we have. Now we call it as greatest leap because it is now going to provide us with the information with less discomfort to the patient. With the less discomfort to the patient. Give me 1 second, guys. One second, some startup issue. Just give me 1 second. Okay, right. This 24 hours pH monitoring, which is a capsule one, which is also called as the Bravo pH monitoring. Right? This is called as a Bravo pH monitoring. What we do in a Bravo pH monitoring is same thing, nothing spectacular about it. Take this as the representation of the esophagus. This happens to be the stomach that you have. Now what I'll do is I will take the upper GI endoscopy, right? I will do an upper GI endoscopy. This is the camera that we have. We'll use your side viewing camera. And once you have this, I will place this pH on the mucosal surface, or the capsule will be anchored onto the mucosal surface of the esophagus, right? So here what we do is the capsule is anchored on the mucosal on the mucosal surface of esophagus. It is going to be anchored onto the mucosal surface of the esophagus. Okay? And this is how we are going to use it. So hence this is going to be more sophisticated. So look at the images. This is how your 24 hours pH probe would look like. This is how your 24 hours pH probe would look like. This is also the same thing. You have a 24 hours pH probe. Now you can see the multiple sensors which are present here. So this is for impedance. Okay? It's an impedance pH monitoring. This is your impedance pH monitoring. So you now know how does a pH probe usually looks like. Okay? This is your Bravo capsule. So this Bravo capsule, you can see it is such a tiny small device. Okay? The chutku sa device hai, and there is the sensor which is in. You place it endoscopically, you remove it endoscopically, and then you will interpret the data. This is your Bravo capsule. Okay? Now, so this is how you interpret a 24 hours pH scale. Now, whenever you're doing a 24 hours pH monitoring, one of the important thing is to stop proton pump inhibitors 2 weeks prior to investigation. So if you're doing a 24 hours pH monitoring, one of the most important thing is to stop the PPI, that is proton pump inhibitors, 24 hours before the investigation is actually performed. Now you will see that this is how the interpretation is going to be given. There's a graph here, it's all hazy and all that. Kuch bhi nahi hai. You just need to understand the basic of this. Okay? So the first thing you will get is, on you have the x-axis, this is the y-axis. On the x-axis, you will see there is time. On the y-axis, you have the pH. Right? Now what you do is, you look at this part. As you go up, the pH increases. As you go down, the pH decreases. Okay? As simple as that. Okay? If I just need to give you a little bit of interpretation, just 1 second. Okay? Now, if you go up, the pH increases. If you go down, the pH drops. Okay? So, above it, I've given a pH of 8. Below, I've given a pH of 0. Okay? Now, these red lines indicates ki how much is the pH fluctuating. Now, I have a baseline. As I told you, in order to know that whether the reflux is happening or not, we have a baseline pH, and the baseline pH is going to be 4. So this line which is going to be here, this determines a pH of 4, right? Now, if the red line is coming below this, that means the pH is dropping below 4. Okay? So, ये जो line है, this is the line which tells you that it is a pH of 4. ठीक है? Normally, आप में मुझ में अगर आप 24 hours pH monitoring करवाओगे, if you get a 24 hours pH monitoring for you and me, most of these lines will be above this. ठीक है? हमारा pH हमेशा pH ऊपर ही होगा. You will not have these red lines crossing this line. The minute you see the red lines are crossing this limit line, that is a pH of 4, I know the patient is having reflux. अब हम क्या करते हैं? This is day 1. ठीक है? If you, I hope you are able to interpret this. I'll just give you, this is day 1. This is day 2. This is day 3, and this is day 4. So this is day 1, this is day 2, this is day 3, this is day 4. Okay? So now, as I told you, we can do a 96 hours pH monitoring. So day 1, day 2, day 3, day 4, so probe laga hua tha, and we are doing the monitoring. Now what I'll do is, I will give a patient on day 1 admit hua hai aur ye pH ka value hai. Okay? I've given proton pump inhibitors. I want you to see only below this line. ठीक है? Day 1 में PPI मतलब patient did not have it, तो ये effect था. Day 2 में देखोगे, we have started on PPI. You see the red line start to decrease. Day 3 में और decrease और day 4 में completely disappear हो गया. You can see on day 4 there are no red lines in this column. pH of 4 के नीचे आ ही नहीं रहा है. मतलब your PPI is helping it to respond. This is a simple interpretation और कुछ नहीं है. ऐसे ही ग्राफ देके आपको फालतू में डराएंगे, कुछ नहीं है. Right? We know that this line which is present here, a pH of 4, is the access line, or I can say it's the baseline. PPI, that is proton pump inhibitors, are not given. Matlab patient was symptomatic. As we said, no, in order to perform this test, I have to stop PPI 2 weeks before. and I do a 24 hours pH, if the patient is having GRD, you will see this is the picture. A lot many times you will see the red line crossing the pH of 4. Now that indicates that the patient is having multiple refluxes, and that is what we call D-Meester score. इन सब का एवरेज निकालोगे ना, D-Meester score of more than or equal to 14.7 आएगा. That indicates the patient is having GRD. In our patient अगर आप देखोगे day 1 पे D-Meester score कितना है, 40.2 है. डे 2 पे क्या हुआ, 16 हो गया. डे 3 पे क्या हुआ, 4.3 हो गया. डे 4 पे क्या हो गया, 0.3 हो गया. As the D-Meester score falls less than 14.3, 14.7, sorry, the patient is going to be symptom free. इससे ज्यादा कुछ है ही नहीं. इसी का इंटरप्रिटेशन इज गिवन, और यही चार्ट आपके बेलियन लॉ में भी दिया हुआ है. आप देखते हो, अरे भाई क्या इंटरप्रिटेशन है, कुछ नहीं है भैया. हुआ है, इट इज ऑल दैट, इट्स अ ग्राफिकल रिप्रेजेंटेशन कि आपकी दवाई काम कर रही है. डिड यू ऑल अंडरस्टैंड दिस? ठीक है. So this is how you diagnose a patient of GRD. Now, once you diagnose a patient of GRD, let's talk about management. So when you talk about the management of GRD, in the management of GRD, the first line management is going to be proton pump inhibitors with lifestyle modification. We say start the patient on proton pump inhibitors with lifestyle modification. Now, in the lifestyle modifications, we'll ask the patient to quit smoking. We'll ask the patient to quit smoking, reduce weight, take small and frequent feeds. Right? So, quit smoking, reduce weight, small and frequent feeds is a lifestyle modification. Along with that, you have proton pump inhibitors. Okay? Now, there is this thing to be understood, that if you're prescribing a patient of proton pump inhibitors, what is the time period that you will give? So the PPIs that has to be prescribed is for at least of 8, right? So many a times it happens, no, that you start a patient on PPI, you start it for 2 weeks, you stop it because symptoms are free. No, you have to give it for those 8 weeks for your refluxes to settle, the lower esophageal sphincter tone to regain back, and obviously when the lifestyle modification is also there, this 8 weeks will also allow the lifestyle modification effect to kick in. So a combination of these two actually does wonders for the patient if they follow it well. Otherwise, they will land up into complications, right? Now, if patient does not have any benefit with this, right? So we have to go to second line. Now, the second line management is going to be surgery. Now, what is the current indication for surgery? Now, when I talk about what are the current indication for surgery in GRD is if there is any complications associated with GRD. For example, or I can say failure of medical management. It is the failure of medical management. That is the first thing. Second, if the patient has developed Barrett's esophagus, that's a high time. We know that you have to revert it back to these patients. If there is presence of stricture, if there is development of a hiatus hernia, or as I told you before, if there is any dysplastic or a lesion that is suspicious of malignancy. If any of these are present, you have to go and hit the patient hard, get the surgery done as early as possible, right? So failure of medical management, stricture, hiatus hernia, as well as suspicious of malignancies are the current indications for surgery. So when you look at the whole concept of surgery, remember the goal of the surgery, it is to increase the lower esophageal sphincter tone. Now, if you increase the tone of the lower esophageal sphincter, the symptoms will resolve, and this can be done with the help of a surgery which is called as fundoplication. Now, there are different varieties of fundoplication. So, we'll talk about the most common one, which is what we call it as the Nissen's fundoplication. The Nissen's fundoplication is what we call it as a posterior. We call it as a posterior complete. The posterior complete 360 degrees fundoplication. It is a 360 degrees complete fundoplication. So what do you mean by this? Now, if you take this as a representation, this is the esophagus, this happens to be the stomach, right? A fundoplication is nothing but a wrap. I have to increase the tone of the lower esophageal sphincter. So how do I achieve this? Nice's fundoplication says, take the fundus of the stomach, bring it behind the esophagus, and then circle it around. As simple as that. I said, okay, I can do that. There's no problem. So I took the stomach, that is the fundus of the stomach, right? And I persuaded in this manner, right? So you see, this is how the fundus of the stomach is being rotated across, and this is how the rest of the stomach was here. So what I did is I took this entire fundus behind. I just reconstruct this area. We wrapped the entire fundus, we brought it here, and once we brought it here, we are going to now suture. Now what you have done is, this is the esophagus. If you look at the lumen of the esophagus, this is the esophageal lumen that you have, right? So this esophageal lumen had to be anchored, right? So the whole objective is, this esophageal lumen which was here, it is getting lax, ठीक है? ये ढीला हो रहा था, इसको जोर से जकड़ना था. To increase the tone, I have to do this. So I took the fundus and I wrapped it around it. तो इसको क्या बोलते हैं? You started from the fundus, you did at the fundus, पीछे से आ रहे हो तो posterior. It is a posterior complete 360 degrees fundoplication, and this is what we call it as a Nissen's fundoplication. This is what we call it as a Nissen's fundoplication. Okay? The other plications that you can talk about, apart from Nissen's, you have Toppet. You have something called as the Toppet fundoplication. The Toppet fundoplication, Dor fundoplication, and Watson's fundoplication. Okay. All of them are partial fundoplications. Nissen's is the only example of a complete fundoplication, right? Now, when you say Toppet fundoplication, it is going to be a partial, we call it as a partial posterior fundoplication. Dor is going to be partial anterior. Watson is also going to be a partial anterior fundoplication. Now, they are nothing but basic techniques that we are talking about. If you want an interpretation of this, if this is the esophagus and this is the fundoplication that we are creating with that of the, so you bring it across here and this is how we stop, right? So you are anchoring it here itself, right? So you are not doing it complete, right? The complete should have been at this point. This is where the fundus has started. If you roll back to fundus, it would have been complete. So Toppet is actually at 270 degrees posterior. We don't want to talk about the angles, but just for the sake of our understanding, I can just put it, it is a 270 degrees fundoplication. That means, what is 270? 90, 90, 90, 390 degrees in a 3 right angle turns, which is called as a 270. Or same thing is going to be happening on an anterior basis. So what you do is anterior 270. So if I take this as a representation, now let's say this is a representation. What I'll do is I'll take the fundus and I will wrap it like this, right? So taking the fundus from here, and we're trying to wrap across it, and then you're going behind the stomach like this. Okay? इसके पीछे से यार. So this is the esophagus, just still in the center. This is the fundus wrap, but you're taking from the anterior surface. अगर आप आगे से ले जाओगे, it is going to be tor. Watson is going to be a 90-degree fundoplication. So door is also a 270 degrees, but this time it is anterior. This is 90 degrees anterior. So 90 degrees anterior mein kya hai? You're taking it here and then you're wrapping it across here. That's it. So this is an anterior wrap that you have created from the Watson's. Okay? Watson's is going to be a partial anterior fundoplication. So these are the various surgeries that you have. Nissens is a 360-degree complete. Then you have top head, which is posterior partial, door partial, anterior, which is partial, Watson, which is anterior. That is going to be a partial fundoplication. Okay? So these are the various forms of fundoplication. The other techniques that you can talk about, which will improve, or I can say the other surgical component that you can take across. Number one is going to be a radio frequent ablation of the G junction. So you induce some amount of fibrosis, so that structural component increases the tone. That is another one. Now this device is what we call it as a Lynx device. This is interesting. Lynx device is basically a magnetic beads. They're basically the magnetic beads. So what is a magnetic bead is, if you take this as a representation of the esophagus, this is the stomach. So what they do is they put magnetic beads at the G junction. Now you see these big magnetic beads which are going to be at the G junction. Now the magnets are going to attract each other, right? So it is like a magnetic bead that is present. So this is the magnetic bead which is going to be present here, and this is going to compress the esophagus. Okay? Every time the food comes in, because the pressure, the magnet expands, the food goes again. It because of that attractive force, it compresses it. So it's an external compression which is going to put across. This is what we call as a Lynx device, or also called as magnetic beads device. Now another newer technique that you have, it is what called as esophagus. Now esophagus is actually an endoluminal stapler. Esophagus is an endoluminal stapler. So what you can achieve with an esophagus, you can achieve a 270 degrees fundoplication, or I can say a 270 degrees wrap. Rather than saying a fundoplication, it's a 270-degree wrap of 4 centimeters length. Of a 4 centimeters length. Now what do you mean by this, right? Now what it does is, if this is the esophagus, this happens to be the stomach, this is the esophagus, and this happens to be the stomach which is present here. So what we do is we put an endoluminal stapler. We put an endoluminal stapler which is going to be in this particular manner. Now this stapler, sorry, this stapler has a reverse hook like this. Okay. You have put the stapler here. I will advance the stapler. Now as I advance the stapler, you will notice that I will bring the fundus close to the esophageal wall. Now this is where my stapler is sitting in this particular manner. I will fire the stapler. Now once I fire the stapler, you will see, once I fire the stapler, you will see the staples would have anchored this area, and then again this will sit together, right? Now this is what we call it as a esophagus or an endoluminal stapler. See? So this is how you will manage your patients of GERD if they don't respond to your medical management. So we covered all the surgical components as well. So fundoplication being a main stem of the treatment if it is not responding medically. Otherwise, these are the other options that you have. The RFA, the Lynx device, and the esophagus is another component. Okay. Then where can we have access to the new bit of we've been telling you this, all the notes of the lectures that we do in BLS, they are put up in my own Telegram group as well as in our PW's group. For me, my group, it is the surgery guide. This is where you have in both Telegram as well as Instagram. It is by my name. It is Dr. Sandeep Seram Reddy. Right. Any questions, any queries, you can just post it down here. post class the notes will be available on this. This is both the Telegram as well as the Instagram ID, right? So just search the, you'll get, I think around 6,000 odd students are there on this Telegram as well as Instagram uh, accounts that we have. So most of the notes which we are done, we actually put it across here as soon as the class is done, right? Right. Thank you so much for joining. The 50th episode of BLS means a lot for us. It just gives me a more and more motivation to do another set of series that continues to happen. We will do the BLS until we finish the entire Bailey and Love textbook. It's a promise. We're not going to leave it anywhere between. We will make sure we complete the entire textbook for sure. That is one. Second, today's the 50th episode. We will have 75th episode. We will have the 100th episode. God willing, we'll have 200 episodes as well. So thank you so much for tuning in, joining in for today. We'll come back again tomorrow, 9 to 10 with another topic. So again, we have done GRD here. So tomorrow, I think we'll pick up somewhere across a diverticular disorder in that context. ठीक है? बेटा कार्डियक मेटाप्लेसिया का मतलब है कि कार्डिया ऑफ द स्टमक में मेटाप्लेसिया हो रहा है. टाइप ऑफ मेटाप्लेसिया सेम, यू विल हैव गॉबलेट सेल्स देयर आल्सो. ठीक है? Got it? क्लियर? कोई सवाल? So, thank you so much, guys. Until then, see you guys tomorrow. Same time, 9 to 10. We'll start with a new topic. Good night. Take care.